Good afternoon, everybody. My name is Victoria Lancey, and we're going to go ahead and get started, just to be mindful of everybody's time. My name is, like I said, my name is Victoria, and I'm the Rural Education Programs Manager here with the Michigan Center for Rural Health, and will be facilitating this program. I would like to welcome everybody to today's special topic, Grand Round on HIPAA security. It's called HIPAA Security Update and Meaningful Use. It's brought to you by Integrated Systems Consultants, and just a few reminders before we begin the program. If you are logged into the webinar portion and have computer speakers, please you can listen to the audio through them. Also, if you are listening to the program through the audio number, and handouts are located on our website. Also, just be mindful, we have quite a few participants on today's line. So once I've muted you, or please be mindful and please keep your phone muted, or hit *6 on your phones to keep your phone muted, just so we're not hearing all of the conversations that are going on in your rooms. Just be mindful of that. Thank you. Like I said before, handouts are located on our website at www.mcrh.msu.edu. Click on the Education tab on your top of your screen, click on the Calendar tab, and find today's date under the More Details. And there you will see the attendance forms, the presentation, and the evaluation link. The attendance forms need to be emailed, faxed, or mailed back to the Michigan Center for Rural Health office. The evaluation form must be completed online. Complete these forms within 2 weeks or by November 3rd, and we will send you a certificate. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenters will address it during the Q&A component. Our speakers today indicate no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I'm pleased to introduce our speakers, Scott Rodica, Security Engineer with ISC, and Mike Zamira, who is an ISC partner. They are presenting. With that, I'll hand the mic over to them. Thank you.
Good afternoon, everybody. This is Scott Rodica. As long as everybody can hear me okay, I'm just going to get going so we can get this class going through.
You're good.
Okay, good. Okay, the first thing I want to bring up, most of our presentation today is based on our experience doing these risk assessments for different entities. And we get a lot of our information from the 2015 National Institute of Standards and Technology and Office of Civil Rights, Health and Human Services 8th Annual Conference. We do want to let everybody know that yesterday and today is currently the 9th Annual Conference going on. So we haven't gotten to those yet. There will be possibly things changing. So just so you know, we are using with the most information we have right now, but there is more information coming probably in the next few weeks, month or so, once we get to process the information. And last year, the things that they pushed as being issues were the breach notification rule and breach activity. Reoccurring audit issues and medical devices were the big hit items for last year. The breach notification rule, there's the renewed emphasis on the breach and what is a breach and what's required. Now, this has also changed throughout the year, so we wanted to go through this. I'm not going to try to read the slides to you, but I have a couple other slides here that will expand on this a little bit. But everybody should know it's about the impermissible use of protected health information. One of the other big things is Office of Civil Rights and Health and Human Services. It says that encryption is kind of a safe harbor. So if you have encrypted information that gets stolen or lost, it is not presumed a breach because it's protected with the encryption. Now, there's a lot of information on this slide, but we just wanted to bring out that the onus is if you have a breach, you must report it. It's important that there's as big of penalties for not reporting a breach when you should have. So it's something you need to understand what is a breach and what needs to be reported. And I'll let you just a quick second to read through. And one last thing, I just want to focus on the last point. It's risk to the data, not risk how the data would harm a person. So when they talk about breach, it's protecting the data. So if you lose the person's name and protected health information, that's a breach, whether that information was ever used or not. One of the big things we're pushing, everybody understands and seems to know that if you have a breach of 500 or more individuals, you have to report it to OCR. What some people are starting to miss is that any breach of data, even a single individual, a single file, must be reported to Office of Civil Rights, Health and Human Services. The difference is the reporting of that breach. If it's a large-scale breach or the 500 or more, you have no more than 60 calendar days from the discovery of the breach. There's a couple minor things. If law enforcement gives you official letter request you not to report it, is the only time that you cannot meet, that you can be longer than that 60-day period. The difference is on a small scale breach for that less than 500, you still have to report it, but it has to be within 60 days of the end of the calendar year in which the breach was discovered. Now, you do not have to wait till the end of the year to report it, but you do have to report it. And we just want to make sure everybody understands that. You can report it when you find it, or you can wait till the end of the year, but it still must be reported. This is an article that came out a few months ago, and I recommend people go look at this website. It is more of a policy guidance document. It has not changed the law. But the government has now said the presence of ransomware or any malware, and there's challenges in this, constitutes, you must presume a breach unless you can prove otherwise. Now, what this says is if you can't prove that no data left your network, it is a reportable breach. I have run across an entity where they had ransomware on a PC, and because of the security measures they had on their networks, they could prove that nothing called back to the ransomware server, so they did not have to report a breach. But for the most place, for the smaller entities in the rural health, nobody's going to have the technical infrastructure to be able to prove that no data left their network. So we're kind of telling people that if you get ransomware even on one PC in your network and you have that has access to any protected health information on your network, you're most likely going to need to notify of a breach. And again, like I said, read that document. It's 5 or 6 pages. I've read it several times. It's very important to read. Again, it's a kind of a policy document of what OCR and Health and Human Services is, the way they're viewing the rules and requirements.
And I guess, Scott, so this is Mike Zamara, just to add into that, one of the things that we're seeing more and more of is hospitals, medical facilities, the folks that are doing some of this ransomware activity have realized that this is a potential breach for you. It is very critical for you to resolve this, so you're more likely to pay the ransom. So medical facilities have become a bigger target in this side of things, even than some of the commercial entities, just because of the HIPAA aspect of this that's come up. So all of you need to be aware of it. Do what you can to prevent ransomware from ever getting on your system. But if it gets there, as Scott said, this is what you're dealing with.
Recurring audit issues that came up last year for OCR. One of the big things they're really pushing is business associate agreements and having them. And my view in viewing these has changed. A business associate agreement per the requirement is that you have to have a business associate agreement with associate that has access in managing, processing, transmitting protected health information. Now, in the past, we say have a business associate agreement with everybody and you're safe. But the problem is what OCR is saying is if you have a business associate agreement, you also have a requirement to make sure that that associate is following the rules that they're required to follow under a business associate agreement. Now, the interesting thing, who's required to have a business associate agreement also are required by the federal law. They end up being a covered entity or a business associate of covered entity and are required to have a risk assessment. So one of the new documents that I'm recommending people, you can have confidentiality agreements with those entities that you work with that don't have access to protected health information. Then they can understand what they have to do if by chance they come across some information. So it is a big deal that not only to have the business associate agreements, but make sure that you're enforcing the rules and the requirements and that your associates are following the rules they need to do. The next thing is the risk analysis. Now, I get a lot of people say, well, we got to do risk analysis for meaningful use, and meaningful use is changing into a new program, so we don't have to do a risk analysis anymore. The thing is if you look in the federal law, it says that a risk analysis is a foundational requirement of security for protected health information, and it's a continuous and ongoing process. So the federal law requires covered entities to do a risk assessment. What meaningful use said, yes, you must meet the federal law, but you also must do your risk assessment at least once a year. Our recommendation to people is, the doctor says even if you're healthy, you should be coming to see the doctor at least once a year. We recommend you should be doing your risk analysis at least once a year, but you also should be doing steps in between there to analyze your risk because things change. For example, ransomware. 5 months ago, nobody thought about ransomware being an issue in the healthcare industry. So if you're just doing it once a year, you could be missing some major risks throughout your industry. And again, that goes to this next slide, the failure to manage identified risk or encrypt the data. But again, if you're not looking at your risk more than once a year, you're not going to manage your risk or identify the risk. They talk about lack of transmission security. This is getting more technical with your IT, but that's basically sending an email with protected data that's not encrypted. That can get you in trouble because somebody could intercept that email and now you have a breach. Not doing patching of software or hardware, doing simple Windows updates on your laptops and your servers. Those can cause big problems. Improper disposal of equipment or paperwork has been problems. We've seen articles where somebody finds a whole bunch of records in the dumpster, and what do? They call the local news. They don't call the entity it came from. It becomes a major breach. And then the other big thing that they're pushing is your insufficient data backup and contingency plan, which I will say this again will loop back to your ransomware, because the easiest way to defend against ransomware once you get it is to have a good backup that you can recover from and get the data. So those are the big issues that came up in last year. Now, this is per OCR right now, and I just wanted to bring this up. I have not met anybody that's been in the phase 2 audits as of yet, but I know they're happening. We're saying they're happening now. It's been over the last couple months. They sent out email to people. I think they're still in the view of the desktop reviews, and I do not know if they've done, but just so you know, Office of Civil Rights and Health and Human Services is starting to be more proactive of going out and checking people. They're not just doing it because you had a breach. They're trying to make sure people are doing what they need to do. And they're also covering everybody, not just the covered entities, the business associates of covered entities, clearinghouses, pharmacies down the road. So it's something to think about. And if anybody has been part of this, I'd be welcome to hear from you, just because I'd like to meet somebody and find out how it happened and what's actually coming out there. Again, who's being selected, covered entities, business associates. They're trying to do across the board. From our understandings, they're doing single office practices. They're looking at those. They're not just looking at the big hospitals. So you in the rural health, you guys could be subject to some of these reviews and screening. And they're saying an entity that does not respond to OCR may still be selected for audits. And I would recommend if you didn't respond, they probably put you towards the top of the list of the audits. Cybersecurity for medical devices. The FDA has been pretty clear about that secure manufacturers are responsible to risk or minimize for medical devices. What they don't do is to say who's going to pay for those risks. So we recommend when people are buying medical equipment, they look at getting included management, maintenance hardware to include security as part of the normal maintenance hardware. We do know we had different clients over the past year that bought brand new CT machines delivered with Windows XP operating systems, which is a critical vulnerability because it's a non-supported operating system now. So they're trying to get the manufacturers to deal with it, but it doesn't help you if the manufacturer says, oh yeah, we'll fix that, just buy this new CT machine that has the newest security on it. We always try to put some humor into here. We have different slides, but just so I can let you read through that. Now the security rule, covered entities. I'm presuming most of you sitting in here are covered entities. It is your responsibility to ensure the confidentiality, integrity, and availability of electronic protected health information. And from my world in security, availability and security are inversely proportional. If you want something really secure, you put it in a big safe and put chains around it, lock it so nobody can get to it. Well, it doesn't make it very available. So this is what really makes this hard, is the government saying you have to secure the data, but also have it available for those who are authorized to use the data when it's needed. Excuse me.
So we've actually seen folks in this industry get in trouble with the Office for Civil Rights because information wasn't available. One of the approaches, I've dealt with a couple of clients where the approach is, I'm just not going to give anybody anything. I just won't share, and that way I can't get in any trouble. Well, one of the spirit of the HIPAA law when it was put into place was by sharing this information, by specialists sharing with family practice doctors and practices, by hospitals sharing results with the primary care folks, you should be able to reduce costs. That was the idea. That was the spirit of all of this. So we have seen some teeth coming back where you weren't sharing information, you weren't making it available to some of the other folks out there. So don't think that you can just pause or just control all transmission and not send anything to anybody and somehow get and ensure you're not going to get sideways with the Office for Civil Rights. It's important that you're able to share.
Okay, now we want to get under the information that's covered. It's really broad when they talk about protected health information. It's individual identifiable health information. Demographic data relates to the individual's past, present, future, physical or mental health conditions, the provisions of health care to the individual, or the past, present, or future payment of provisions of health care. Now, I saw an article once where a small, I don't know what kind of practices was, but they went to a small claims court because they had all these patients that weren't paying their medical bill. So they had the patient's name, and they happened to include the diagnostic code of what they did, the billing code of what the patients weren't paying for. And OCR and HHS says that's a HIPAA violation. It has the name of the person, and that diagnostic billing code directly relates to the past, present, or future physical or mental health conditions of that patient. So you have to be real careful. Things that don't seem important, people ask us, is a chart number safe? Can I do a chart number with the condition? Well, if you can easily identify that chart number matches patient X, then you can identify who that patient is. So it's really broad definition, and you have to be really careful when you're using any of the information that could identify the person here. Now, the provisions of sharing for PHI are pretty clear. It's treatment, payment, business operations with the individual's express permission or consent. Again, it's pretty clear. If you have a billing house, they need to have access to the health information so they can bill insurance. If you're dealing with a specialist, they might need to know test. Now, where it gets a little sticky is this minimum necessarily rule. And we're starting to run into this with some of the new electronic healthcare records. A lot of the new electronic healthcare records, if you have access to the chart, you have access to everything. And what the rule says is you should only be given enough information that's needed for the specialist or the entity to accomplish the intended purpose. We don't have a good answer for this right now. We just know that you don't want to be just automatically sending the complete chart if you're sending it in a mail or other ways, if you can help it.
Yeah, I would just add in that I think the solution, so some of the systems out dealing with medical records have the ability for you to mask certain portions of a person's file when you're sharing with another specialist, or if you're having to share with folks who are doing the billing. You have to look into that option for your systems, and you will see that more of the folks who are writing the software that is being used for this are bringing that into play because it's become a bigger issue. I mean, out of the gate, it was, hey, I have these affiliate practices that need access to their patient records, so I'm just going to open up the whole system to them so that they can see this information. Well, that opened so that they could see other practices, patients that weren't theirs, and they could see stuff that really didn't pertain to how they were dealing with that patient. So they're dealing with it right now. I think you need to be asking the question of whoever is handling your EMR system, that you have the ability to mask some of that.
Policies and procedures. The way I explain to people the difference between a policy and a procedure, to me, a policy is something that's written. It is somewhat withstanding. It is signed off by the highest level of people in your organization, if it's a CEO or if it's the owners. A procedure is something that may or may not be written down and can be signed off by like a manager, a nursing manager. But really, they're kind of the same thing. They need to be, say what you're doing and do what you say. It is no good to have a policy or a procedure that says, I'm going to do this item XYZ, and you don't do Y anymore, because that can get you in as much trouble as not having a procedure at all. So what I tell people, and one of my famous sayings from government days, if it's not written down, it's not done. It doesn't mean you need everything written down, but you need a way that's written down that can document that you do something. So if you have a procedure of how you take blood, the documentation is you have in the chart the blood pressure was taken. So you need to look at these as they need to be how you actually do business, and actually that everybody, you could walk up to the person that follows it, actually knows it and does it that way. There's another big thing is you need to train your staff. Training is a continuous and ongoing process. It's not just new hires. It's also a change in the responsibility for the patient. It's as policies change, excuse me, and it's also as the risk environment changes. If you realized all of a sudden that ransomware is more important, you need to make sure your staff knows that they need to be looking out for the things for ransomware. So training is a continuous and ongoing process. And then maintain written documentation that you did training. We had a staff meeting. Here's a list of the people that are at the staff meeting. Here's what we covered. You documented it. And anybody has more questions, please get a hold of us. We'll help. I have more ideas and different things that when we deal with our clients to help them, just simple ways that can document it, but still meet the requirement to have policies and procedures. Now, safeguards for protected health information. My background comes back. I was an Army officer. I'm hardware based for electronics. Cybersecurity's newer in my background. But my view is if you don't have physical security, you can have the best cybersecurity in the world and somebody can walk in and pick up your server and walk out the door with it. You lost the game. Physical security needs to be there, so you need to make sure your office is locked, the cabinets are locked, the information secured, because it's not just the digital world. Now, we focus on the digital world because we hear about the Anthems and the Hollywood Presbyterian hospitals, but make sure you're also, do you lock the door at night? Do you lock the windows? Going home and leaving the window wide open doesn't help you. Now you get the technical securities, using passwords on every desktop, portable devices. Are you encrypting your data that is leaving your facility? Again, you want to do this in steps. And the last thing we always tell everybody, you want to instill a culture of compliance. So you want everybody to think, I really should lock my screen when I'm going to the bathroom because I don't know who could walk into my office and have access to my computer that could have protected health information. So you want to get your people thinking on the idea that security is important and it's required. And then again, with manage your business associates, they also understand that if it's important to you and you're pushing down to them, they need to understand it needs to be important to them. It's not just your problem. Security is everybody's issue. Now, here's the thing, the examples of a business associate. A lot of this information comes right off of healthit.gov, and they go through, I'll let you read through them, but again, it's people who have need to access, process, and or transmit information, protected health information. Now, one thing I'll bring up, I read an article that says law firms are some of the biggest violations of HIPAA, and it happens to be these law firms that are dealing with workman's comp cases. Well, part of the case, they have the complete health record from the person being hurt on work, and they're not securing that data. If you're working with a workman's comp type organization, they do have protected health information, and they do fall under requirements of HIPAA. Another is the HR department. If you have companies that are doing with their own HR, with their own workman's comp, a lot of times the human resources servers also fall under holding protected health information. So just something to look for.
Yeah, the other thing I would add, if you're trying to figure out if somebody is a business associate, maybe sit down with your financial folks and go through all the vendors that you're paying and think through, are these people coming into contact with any protected health information in any way? And that will help you to assess whether a business associate agreement needs to be put in place. So.
Now, this is one that I got off the website. We used to tell people that, yeah, let's be extra safe and call a janitorial service business associate. This is where my views have started changing. According to HHS website, a janitorial service is not a business associate because it's not part of their normal job to come in contact with protected health information. They could incidentally come in contact because somebody else didn't do what they're supposed to do. But that's where we talk about a confidentiality agreement you can have with your janitorial service so they understand if they find protected health information, what are they to do with it? So you're not forcing on them to do the risk assessment. You're not forcing them to do some of the other requirements the rules do, but you still are informing them that they still have an obligation to protect the data if they find it. So again, when you look at those, make sure it's part of the person's normal job to handle the protected health information or use it. If they're like a janitorial service where they might come and contact it, then you might want to talk about a confidentiality agreement. And again, I'd also talk with your legal people because they understand this real well too, and you can ask us questions. Again, this is where you want to put the onus of the requirements of people who need to follow it, but also set up the information to keep it safe in case something accident happens.
So these next two slides, I don't want to spend a ton of time on these because frankly, it sounds self-serving as all heck because we perform security risk assessments. And the next two slides really just, it's what Scott already mentioned to you a few slides back. These are required. If we are talking about the fact that you have responsibility, whether it's for your friends and neighbors' health records because they happen to go to your particular practice, the patients in general, we need to be doing stuff to make sure that we've got this stuff under control and available where it needs to be. So that's really these next two slides just point out where in the regulation this is laid out, and we end up in a lot of debates with people who want to say that, hey, we're not required to do one of these because of A, B, C, D, E, whatever. And frankly, I've gotten sick of having the debate because it's pretty clear you need to, and where people do get sideways, it's because they started out by not doing this sort of work. So I don't know if you want to add anything, Scott.
No, that's perfect. Again, this is the culture of security. This is us kind of backing up why we're saying this. Pretty clear. And again, this other slide, you can download it. This actually comes from an article from HHS's website and just guidance. So I'll let you guys can read that offline and download the slides. Now we want to get some results that we've come across. These are taken from Office of Civil Rights websites. They are real enforcement actions. $1.5 million is the max penalty per year per violation. Now, one thing I'll focus on that you got to be careful about, what they deem a violation could be an individual patient's health record. So if you have 500 individual patients, according to the rules, it could be $1.5 million per patient record. The other thing is the fines that OCR and HHS collects goes into their operating budget. And then they use them to do more investigations, more audits.
Yeah, this is basically a self-funding enterprise. And the point being, if you attend any of the Office for Civil Rights seminars where they're talking about their approach and what they're trying to do, just to make this clear, they're not trying to put hospitals and medical practices out of business by any stretch. But when they look at, if there's a breach situation or they're in an audit situation, they are looking, if they have issues, they are looking to assess a fine that will hurt. I mean, that's their they actually say it in a couple of their seminars that they don't want to put you out of business, but they want it to hurt, so you pay attention to it, and so you do something about it. So it has a lot of teeth. And again, this isn't from a scare tactic standpoint. This is so that people give some thought to this as to how you want to deal with it. But it is real. We are seeing it happen. We've dealt with some clients who have interacted with the Office for Civil Rights. Luckily, we haven't been in a situation where any of them have been in a fine situation. But it certainly is real, and people are dealing with it every day.
Now, the next thing, we'll get the things that we're not trying to scare you, but these are facts of things that have happened. September 2016, a $400,000 settlement highlights the need for encryption of HIPAA business associate agreement. So basically, this health system agreed to pay the fine. Now, when these numbers are the fine they paid to OCR HHS, it does not include the money they spent to protect the systems, to fix the systems, and or the money that may take because now they might be audited more frequently because they already had found not to meet the standards. But they had lost unencrypted backup tapes containing 14,000 patients' information. Again, they would have been encrypted and they lost it. It wouldn't have been a breach. They probably wouldn't have got fined. But they're serious about doing this. They also found they had a business associate agreement in place, but it hadn't been updated, again, since 2005. Again, this is where my recommendation is. Doctor says even if you're healthy, you should be looked at once a year. You may not have to re-sign a business associate agreement, but I believe it should be looked at maybe once a year, at least reviewed to make sure the company still has the same owners. Because the company changed owners, you no longer have agreement with those owners.
Well, I'd also add on that front, the business, at the Office for Civil Rights website under HIPAA, they give some guidance as to what information should be in a business associate agreement. And we deal with a lot of different law firms that do keep up to date with that, take a look at it, and they modify the agreements. And it doesn't change every year, but I think about 13 months ago was the last time they overhauled the whole thing. So make sure you're working with your in-house counsel or your attorney and looking at those documents, because what they're bringing in is additional language because of situations that occurred with other practices and trying to better cover some of these pieces. So.
Okay, here's a bigger one. March 2016, a $1.55 million settlement. Importance of a HIPAA business associate agreement again. I mean, again, you get an idea. I'll let you read through that. And again, you can look at these in more in depth when you download the slides. Here's an Unpatched Software case, 2014. Now, this was a Anchorage Community Mental Health Service agreed to settle potential violations caused by unpatched and unsupported software, $150,000. Now, I remember reading this. They're a nonprofit organization providing behavioral health care services to families in Alaska. So you can see, yes, it's not the $400,000, but $150,000 for a nonprofit organization is something that I'm sure hurt quite a bit.
Well, and so unpatched, so I get this question about, well, so I didn't patch my software. What's we get around to it, we do it once a month or we do it once a quarter. The issue is that those patches are going out to everyone, the patches that need to be made. And where someone who's looking at maybe getting some ransomware on your system, maybe doing something to harm your system or to steal data, they also know that this is where the patches are. So what they do is they use that information and look for entities that they can maybe get in the door on or in the back door by going through some of these unpatched areas. So that's why it's pretty critical. Once that information's out there, you need to be using it. So
that one other point I'll say, this is also the reason why OCR and Health and Human Services looks at unsupported operating system like Windows XP that Microsoft no longer supports as a critical vulnerability, because any new vulnerabilities found you will not have patches for. So just to think along that lines. 2015, this is to kind of force and show that HIPAA is not just about electronic. This was paper records. Again, pharmacy threw stuff in the dumpster versus having it destroyed properly. And again, $125,000, and this is a pharmacy. This isn't a big hospital. This is something to think about. Again, we want to keep this. You want to build a culture of compliance. You want everybody to be thinking that security is part of their job, because we can't do this without all of our employees trying to protect us. And frankly, what we say in security world, for an attacker to win, he has to get through your defenses 1 out of 100 times. For us to win in security, we have to stop the attacker 100 of 100 times. So we're only going to do this if we get everybody working together. And then one last joke because we kind of like putting up slides, because yeah, it's serious stuff, but we also try to keep it light.
Well, and the other piece that I'd add on this, though, too, is make sure from a culture of compliance. Again, just looking at the joke there, it's kind of, hey, I can't share anything with you because HIPAA tells me this is where I sit. And if we do treat it that way and don't embrace it, we are going to have those situations where people do kind of look at this a little bit as a joke. You got to get from the top of your practice, the doctors who are leading it, to the person who is entering data into the spreadsheet. Make sure everybody understands why this is important. And I think you have a very good chance of keeping your arms around this and making sure you limit any sort of exposure. If you treat this as this is just a necessary evil and we'll do whatever the minimum required to get by, I think you're asking for a little bit of trouble. So try to take this as the spirit intended, which is try to use this to better your practice.
One last thing I didn't mention on the breaches we showed. All the newest breaches are coming out right now. They're saying 2016, but those agreements and fines being assessed are from breaches that happened most likely in 2013 or earlier. We have not seen the agreement between Office of Civil Rights, Health and Human Services for the fines and the things that need to be done for the instances like Anthem. So just so you start to realize, these are, it's a big deal, and we're behind the curve in what we're seeing, how it's being enforced too. And then the last thing, here's some websites that I use. The HIPAA Journal is just a quick, easy site that starts talking about these big breaches. They talk about some of the news coming out. They do a fairly good job to give you a cursory information so you can look in more in depth for more information for you. Again, going to the source, Health and Human Services, Office of Civil Rights, their website's really good. The Office of National Coordinator, healthit.gov, that has some really good information on some trainings that you can use for teaching for cybersecurity. And then there's, again, healthit.gov, again, there's more information. And then last, just because we are a company, just so you know that we do, I live security. My job is security. Most of my work is in the healthcare industry right now, but we do other security. So if you have questions or concerns, I'll be happy to give you my opinion. That being said, I am not a lawyer or legal. I do not give legal advice. I can give recommendations based on information that I understand. And from there, we will open up any questions that people have, and I'll try to look at if any questions were written up.
Okay, we'll now open up the lines for questions. I will go ahead and unmute all of the lines, so just be mindful again of all of the conversations that are going on. So please feel free to use the chat box as well. Okay, so now all the lines are unmuted. So if we have any questions or comments, feel free to share them now.
Again, if anybody has other questions, I know Victoria has my information. If you feel more comfortable doing it individual, I have email. I will answer to the best of my abilities.
Feel free to type it into the chat box, and I can field them that way as well.
I don't think anybody's going to say.
Are there any questions or comments? If we don't have any questions or comments, your evaluation, and I can pass them along to our presenters, or you can feel free to email me and I can again pass them along to our presenters, but I won't keep it long. Thank you for joining, everybody.